Hello, my name is Hana Mobasseri. I will be a junior at Euclid High School. This summer I was in the science internship program, and today I'll be presenting on the treatment of ulnar collateral ligament injuries of the thumb using a dynamic hinge splint. So just some background information on the anatomy of the thumb. There's three bones: the distal phalanx at the tip, the proximal phalanx, and the metacarpal bone. The metacarpal phalangeal joint, also known as the MCP joint, is located between the proximal phalanx and the metacarpal bone. The thumb also has the ulnar collateral ligament, which is shortened to UCL. The MCP joint is quite small but has a major role. It connects the thumb to the palm and is essential to the proper functioning of the thumb. The UCL helps stabilize the thumb and aids us in grasping and pinching. Therefore, when damaged, it causes instability. Complete ruptures of the thumb UCL at the MCP joint are commonly known as gamekeeper's thumb or even skier's thumb. It's most commonly found among skiers or people who sustain a fall onto an outstretched hand. It is a trauma injury, however, it can also develop over time by progressive injury of the UCL. It may be stressed and torn over time due to specific repetitious activities that stress the MCP. Some symptoms are pain at the base of the thumb or possible swelling. An important indicator is feeling an instability or weakness of grasp between your thumb and index finger, or even tenderness to the touch along the index finger side of your thumb. Blue or black discoloration of the skin over the thumb is a symptom also. Thumb pain that worsens with movement in any or all directions is also an indicator, and possibly even pain at the wrist. There are different ways to treat gamekeeper's thumb. If there is an acute partial rupture, then 3 to 4 weeks of immobilization in a special cast or splint can be effective. With a total rupture, however, known as a grade 3, patients may have surgery, then use a splint, or automatically go into a splint for a duration of 6 to 8 weeks. So here's some background on the types of splints that could possibly be used. A static splint is a standard treatment for a UCL injury. Immobilization of the thumb is very conservative and doesn't allow for much movement. Motion exercises are added a few weeks into recovery and only occur a few times daily. Here's a picture of a static splint that would be used in a standard treatment of gamekeeper's thumb. As you can see, it really doesn't allow for the thumb to move, and even if you manage to wiggle around, you can't control the movement. Since average range of motion exercises are not frequent and start at a later stage in recovery, excessive efforts to recover a full arc of motion may overstretch or undo early ligament healing. This results in chronic pain and instability. To avoid such occurrences, a dynamic hinge splint was designed. It would also allow for the degree of controlled thumb MCP motion throughout daily activities. The dynamic hinge splint is custom-made and allows for less conservative immobilization. Movement of the thumb is stable, yet allows the patient to move injured thumb in a secure motion. Motion exercises begin early in recovery while the patient is still in the splint, and they happen throughout the entire day. The hinge splint allows the thumb to slightly maneuver, but not enough to disrupt the healing, and it ultimately leads to a stronger UCL due to active motion at an earlier stage in recovery. Here's a picture of a patient grasping a doorknob, which would not be possible in a static splint. The patients can clearly do some daily activities, ones that don't stress the UCL or the MCP. A limited arc of motion, approximately 0 to 35 degrees, is used to minimize extreme stress to recovering tissues. A static immobilization results in increased joint laxity, limited ligament structural strength, reduced collagen formation, and overall joint stiffness. My hypothesis was that the use of this dynamic hinge splint can prevent that and still give the patient a well recovery. Sufficient patient education is vital to ensure compliance with this full-time splinting program. Patients are told to remove the splint for hygiene purposes while making sure to limit efforts to move the MCP joint and avoid grasping and pinching altogether. Patients are guided on how to modify daily repetitious or aggressive grasp and pinch activities, and recommendations were provided on a case-by-case basis, depending on their occupation and leisure activities. Regular follow-up visits are scheduled to ensure the splint is fitted well and to monitor pain levels. Patient follow-ups record the current pain level and sometimes the current range of motion. During the initial evaluation, patients determine what goals they aim to achieve by the end of therapy. Here's a table of how many times non-surgical patients did follow-up. The top row is the number of visits, and the bottom is the number of patients who came that many times. The majority of patients came to follow-ups on an average of 1 to 2 after receiving the splint. However, 19 patients only came for the initial evaluation where they first received the splint. This table represents the patients who did have surgery. Obviously, they had more critical or even multiple injuries, which is why they continued to follow up so many times. Most patients find pain relief early. Some patients required a few additional weeks of splint wear, depending on results, and that may only be necessary for a limited part of each day. The picture on the left shows a patient after recovery. They're able to move their thumb and have achieved a functional range of motion. On the right, they show their ability to pinch. Complications were minimal. Problems related to the splint included the breaking of tubes, skin irritations such as rash, and lack of patient compliance. Patients who returned after their initial evaluation recorded less pain and an increase in ability to use their injured thumb. They also stated whether or not their initial goals had been met by the end of the therapy. Patients were satisfied that the splint allowed them to return to work, which was one of the major goals. Of the 51 patients recorded in the study, 32 of them returned and 19 of them didn't. 19 only went to their initial evaluation where they received the splint. From the patients who did return, 26 of them met their goals, and the remaining 6 were either improving or on track to meet their set goals. Full range of motion at the MCP joint is not considered an absolute requirement. Instead, a functional, secure thumb without pain is the desired goal. Patients are able to continue daily activities within functional limits and without pain. Treatment using a custom dynamic hinged thumb MCP splint shows success in compliant patients. As long as patients follow the guidelines given by the therapist, recovery from a UCL injury is possible without the need for a surgical procedure. If the splint is worn after surgery, it allows for an easier recovery without pain or stiffness in the end. Ultimately, patients who had early limited active motion experienced less stiffness and pain at the MCP joint throughout recovery and in the end. Limited exercises with a dynamic hinge splint at the beginning stage of recovery results in less pressure on the ligament and joint than if a cast or static splint was worn. If a similar study were to be conducted, I would recommend for there to be a stronger push for follow-ups, and I would also recommend that at these follow-ups for evaluations to be completed on the pinch, grasp, and average range of motion. I would like to say thank you so much to Ernest Mashad, my mentor, the Occupational Therapy Office, Stetson Thacker, my peer mentor, fellow interns, and the Office of Civic Education Initiatives.